Okay, in this video I'm going to talk about celiac disease. Okay, this is the third video on malabsorption. Celiac disease is a permanent intestinal intolerance to dietary wheat gliadin. Okay, so it is intolerance or allergy to what? To dietary wheat gliadin, type of protein that present in the wheat, the rye, and the barley. Okay, so and related proteins. Not only gliadin is the cause of celiac disease or the predisposing for the celiac disease, also a gluten protein that is a component of gliadin is a part of celiac disease. Okay, so what really happens that the gluten protein in gliadin and other proteins will create a type of allergy in the small intestine. The small intestine will not be able to tolerate this protein, so it will trigger the immune system to play a role. Okay, and that will lead to inflammation and mucosal lesions in genetically susceptible individuals. So celiac disease is genetic predisposed disease. Okay, about 95% of celiac disease patients have positive HALA-DQ. Okay, and about 10%. Okay, we have about 10% prevalence in first degree siblings. So it is a genetic disease. Okay, so celiac disease has other name like gluten sensitive enteropathy, and by now we know why is it gluten sensitive enteropathy, because there is sensitivity to or allergy to gluten, which is in wheat, rye, and barley and other things. Okay, so this is the wheat for who doesn't know them. Okay, let's just watch this video.
In celiac disease, a protein in wheat, barley, and rye called gluten triggers destruction of tiny hair-like protrusions called villi in the small intestine. Normally, villi allow vitamins, minerals, and other nutrients to be absorbed through the wall of the small intestine into the bloodstream. In celiac disease, gluten triggers the immune system to damage or destroy the villi. Instead of being absorbed, fats, proteins, minerals, and vitamins are eliminated in the stool. Decreased absorption of nutrients, or malabsorption, can cause malnutrition and other long-term problems.
Okay, and let's now move to the clinical presentation of celiac disease. How does it present? I actually categorize the celiac disease presentation into two categories: the gastrointestinal manifestation and the extra gastrointestinal manifestations. Okay, the gastrointestinal symptoms are mostly due to atrophy of the small bowel mucosa and due to malabsorption that happens as a result of celiac disease. Okay, you will have a diarrhea because of what? Because of the malabsorption and the remnant of the bowel component in the bowel. It is not absorbed anymore, so you will have a diarrhea, and the malabsorption also will lead to weight loss. Okay, abnormal abdominal distension also. Okay, vomiting for the same cause, anorexia, and failure to thrive. As a result, you have a malabsorption, you have weight loss, of course you will have failure to thrive. Aphthous ulcer also is a presentation, GI presentation of celiac disease. These are mainly the gastrointestinal manifestations. The most important are the chronic diarrhea, weight loss, okay, abdominal distension, abdominal pain, vomiting, anorexia, failure to thrive, aphthous ulcer. All are possible manifestations of celiac disease. The extra gastrointestinal manifestations, to understand them, you have to imagine what the malabsorption of things can lead to. Okay, in the hematopoietic system, hematological symptoms are mainly due to iron deficiency. Okay, there is no more sufficient iron absorption, so iron malabsorption will lead to iron deficiency, anemia. What about neurological symptoms? You will have also thiamine and vitamin B12 deficiency due to malabsorption. And thiamine, vitamin B12 deficiency will lead to peripheral neuropathy, epilepsy, irritability, okay, bilateral occipital calcification. All of them are possible things to happen in celiac disease. What about endocrine system? Endocrine system, you will have decrease in calcium, vitamin D absorption, okay. So short stature, very important. 10% of isolated short stature is found to have celiac disease, okay. And secondary hyperparathyroidism. Why? Because you have decrease in calcium, and you know that the parathyroid hormone is to increase the creation of calcium and work by feedback. So if you have decrease in calcium, it will tell the parathyroid hormone to secrete more parathyroid, the parathyroid gland to secrete more parathyroid hormone. So you will have hyperparathyroidism, short stature secondary to the hypocalcemia and vitamin D deficiency. Also, the vitamin D deficiency and the hypocalcemia in the skeletal system will lead to osteoporosis in a lot of cases, okay, or enamel hypoplasia of the teeth. What about the muscular system? Due to malnutrition, you will have muscular atrophy, sometimes arthritis, okay, due to the immunity. You know that celiac disease is an immunological disease to a gluten protein, so you may have association with arthritis, okay. Also rickets is possible due to hypocalcemia. Let's get back to the endocrine system. I forgot to tell you that celiac disease is found to be associated with a lot of autoimmune diseases like hypothyroidism, like type 1 DM. Actually, there is about 10% co-concurrence of celiac disease with type 1 DM. Okay, Down syndrome is also associated with celiac disease. Selective IgA deficiency. Selective IgA deficiency, very important. Don't forget these things, okay? So I advise you to pass over the system by system, okay. Start by the hematological. Think what will happen to hematological system. You will have iron deficiency, iron malabsorption, so anemia. What happens into neurological system? You have vitamin B12 and deficiency, and the symptoms of vitamin B12, thiamine deficiency. In endocrine, calcium and vitamin D malabsorption, and so on, okay. Dermatologically, you will have dermatitis herpetiform, okay. This picture is to show you dermatitis herpetiform, and actually dermatitis herpetiform are itchy vesicles on the extensor surfaces. So this is the extensor surface of the forearm, okay, and so they are itchy vesicles on the extensor surfaces, and they improve by eating gluten-free diet. So this is the dermatological symptoms, dermatitis herpetiform, but also alopecia areata, also due to immunity okay, defect, or erythema nodosum. Alopecia areata, you know, loss of hair in some places. Respiratory system may be affected also by what we call idiopathic pulmonary hemosiderosis. So please remember them systematically and you will never forget them, okay. Now let's get into the clinical spectrum. I told you that these are the clinical presentations of celiac disease, but does that mean that in every case of, or in each case of celiac disease, we'll have all these symptoms? No, we have a clinical spectrum of celiac disease that graduate from asymptomatic sometimes, okay, asymptomatic disease to fully symptomatic disease, okay. So we have silent celiac disease. In silent celiac disease, we have the disease, okay, but you have no apparent symptoms, okay. You have positive histological findings, so you have celiac, you have serology positive for celiac disease, but the thing that you have no symptoms is the reason behind calling it silent celiac disease. You may have also symptomatic celiac disease, the symptoms that I mentioned, okay. You may have latent celiac disease. What do we mean by latent? You have latent means that you have normal histology, no indicators for celiac disease, okay, but at some point of your life you have or develop a gluten dependent enteropathy, okay, but at the time you have normal histology. So this is why we call it latent, because late in your life you may have celiac disease. So it may be in 40s, 30s, sometimes in 50s, okay. It looks strange, but it really happens, okay. Potential celiac disease. In potential celiac disease you have positive serology of celiac but negative histology, and I'm going to talk about, when we move to the diagnosis of celiac disease, I'm going to talk about the serology and the histology, okay. Potential celiac disease, you have positive serology, but the serology actually is not that specific and sensitive in some cases, okay. So you might or might not be symptomatic in this potential celiac disease. So to be definite celiac disease you have to have positive histology, okay. If it is negative histology then it is potential. If you have positive serology, you can't confirm the presence of celiac disease by serology itself. So these are the clinical spectrums of celiac disease: symptomatic, silent celiac disease, positive histology without symptoms, latent celiac disease, negative histology. At some point of your life you develop celiac, okay. And potential celiac disease, you have positive serology but you have negative value of the confirmative test, which is the histology of the celiac disease. Now let's move to the diagnosis, how to diagnose celiac disease. We have what we call SPGAN criteria, okay. And this criteria, you have to have abnormal small intestinal mucosa. So by biopsy, if you take a biopsy, it will be abnormal biopsy, and clinical response to gluten-free diet. So the doctor suspects the patient to have celiac disease, for example, okay. He did a biopsy and the histology was abnormal. So this is the first point. So he asked the patient to stop eating gluten. He gave him a gluten-free diet and the patient responds. So this is the second point, okay. And not only clinically respond, also histologically respond to gluten-free diet. So this is the third point, okay. In the past they used to put fourth point, which is histological relapse after gluten change. They used to gluten challenge. They used to challenge the patients with the gluten. They give them a gluten and after some time they do a biopsy and see if there is any sensitivity. But nowadays we have revised ESPGAN criteria. This point is not there anymore, okay. So re-challenge test with the gluten is not advised to be done anymore. It's not that important, except in some cases. What are these cases? To do challenge test of gluten if you have below than 2 years age of diagnosis of celiac disease, okay, below than 2 years, and if you have atypical biopsy or the biopsy was not done, so you can do re-challenge test. If you have atypical biopsy, you are in a doubt, is it celiac or no, so you do challenge test to confirm, okay. If the age of the patient is below 2 years, you do it. If the biopsy is not even being done, you can do it for the first time, okay. So this is the criteria for to diagnose celiac disease: abnormal small intestine mucosa, a clinical and histological response to gluten, okay, is enough to diagnose. Also, you have a screening test for celiac disease, which are the IgA anti-endomysial and tissue transglutamase antibodies, okay. And the tissue transglutaminase antibodies actually is the most important, okay. Celiac is an autoimmune disease. You have immunity that will immune antibodies that will attack the small intestine, and from these antibodies we have the transglutaminase antibodies, we have the anti-endomysial antibody. Okay, so if you detect these, then you can suspect the presence of celiac, and actually they are very sensitive and specific. Okay, but you have to check IgA levels, because in the patient that have IgA deficiency and you find no transglutaminase antibodies or TTG, it is not specific. Okay, the test is not specific anymore because you have no IgA antibodies. IgA antibodies are the antibodies that mainly attack when you have celiac disease. So in this case, if the patient has IgA levels that are low, okay, you use IgG antibodies. So to screen for celiac disease, you have to check transglutaminase antibody, okay, plus IgA levels. If you have low IgA levels, then you move to check IgG instead of IgA. Okay, also we have to check water soluble and fat soluble vitamin deficiency investigations of celiac disease, because you may have vitamin K malabsorption and other things. Okay, the tests I told you in the previous video about the malabsorption. Now let's move to the complications of celiac disease. What are the possible complications of the celiac disease? Actually, the most important complication to be mentioned in celiac disease, the malignancy. Okay, and malignancy may happens even in the silent celiac disease. Okay, and the type of malignancy is small bowel lymphoma. The risk increased by 50 to 100x. Okay, and more in elderly patient diagnosed with celiac disease. So small bowel lymphoma is very important complication of celiac disease. Okay, and the specific type of small bowel lymphoma is intestinal non-Hodgkin lymphoma. So please remember that. Now let's move to the Marsh classification, or the histological classification of celiac disease. We classify the celiac disease histology according to what we call Marsh classification into actually 4 grades. In the grade 1 you have normal mucosa. Okay, no problem. I'm sorry, this is grade 0. In grade 1 you have increased number of intraepithelial lymphocytes, so it's an immunological reaction. So first thing to happen, or the first grade, is to have increased intraepithelial lymphocytes, usually exceeds 20 lymphocytes per 100 enterocytes. Okay, this is grade 1. After that, in grade 2 you have proliferation of crypts of Leprechaun. Okay, so first in grade 0 you have normal mucosa. Grade 1 you have increase in the epithelial lymphocytes. Grade 2 you have proliferation or hyperplasia of the crypts. Grade 3 you start to have a damage of the villus. You have variable villus atrophy, then partial villus atrophy, then subtotal villus atrophy, and the end of this story is the total villus atrophy. Okay, this is grade 3. Okay, in grade 4 you have hypoplasia of small bowel architecture, hypoplasia. So please remember this grade. Normal mucosa. Grade 1 you have lymphocytes. Grade 2 you have hyperplasia. Grade 3 are when we start to have villus atrophy and changes. Okay, and actually there are multiple causes that may cause partial or subtotal villus atrophy. For example, the celiac disease is known to do subtotal or total villus atrophy. Giardia also associated with subtotal villus atrophy. The cow milk allergy is associated mostly with partial villus atrophy. Okay, after chronic enteritis we may have also partial villus atrophy. So important to remember the causes of partial and the subtotal or the total villus atrophy. Okay, so this is on the photo. Here we have increase in the no, here is the grade 0. We have normal histology. In grade 1 we have infiltration, so this is infiltration by lymphocytes. In grade 2 we have a crypt hyperplasia. So okay, I'm sorry, this is a crypt hyperplasia. In a grade 3 we start to have villus atrophy, subtotal, total, partial, and so on. Okay, and grade 4 we have hypoplasia. So this is the Marsh classification of celiac. The end story, or the end of the story of celiac disease, the management. How to manage celiac? You manage celiac disease by giving gluten-free diet. So it is an allergy to gluten, and to solve this problem you have to give gluten-free diet, and this should be under the supervision of dietitian. Okay, when to stop a gluten-free diet? Never stop a gluten-free diet in celiac disease. Okay, it's a lifelong management of celiac disease. So it is more an allergy than to be a disease. It's good to tell your patient this so that they can feel relaxed. Okay, you just to stop gluten-free diet, and actually it's a really challenging thing to do, but this is what to be done. Okay, actual prognosis of celiac disease is excellent if patient compliant with a strict gluten-free diet, but if the patient is not on gluten-free diet, they carry a risk of developing the malignancy, small bowel lymphoma, the non-Hodgkin type. Okay, even if the patient is asymptomatic, he should be on a gluten-free diet to avoid the transformation into the small bowel lymphoma. Okay, this is all about celiac disease. Thank you very much for watching. See you in the next video.